Awesome. So thank you so much for having me, Dr. Close-Reed and the whole team. I'm really excited to be here with all of you. As Nicole pointed out, this is definitely our area of passion and work. And I just am really excited to bring those worlds that, from my perspective, together and talk to you today about oncology related medical issues. And I gave a similar presentation on a similar topic earlier this year. And based on that feedback, I've actually really changed this talk. And so when I presented earlier this year to the Excel group, we talked about screening and triage, and then we highlighted a few medical conditions. And everyone at the end wrote me and said they just want more on the medical conditions. And so that's what we're going to focus on today. There's a lot of content, and usually I like to have slides that are beautiful and not much text, but I know you'll be receiving these slides. And so there's a lot of information on the slides for you to take with you to put into practice. And if you've done the Thrive training in the past, this is all new content. This isn't part of it right now. And so I really hope this is useful for all of you listening. As Dr. Close-Reed pointed out, so I am a resident in physiatry, physical medicine and rehab. And if you haven't heard of what that is, you're not alone. It's a smaller specialty where we really focus on working with people after a diagnosis or after an injury. And it's a 5-year specialty after medical school. So we work with patients with spinal cord injuries, after a stroke, with sports medicine issues, or with cancer, and lots of other different chronic diseases as well. And also a clinical exercise physiologist, and then did my research with Dr. Close-Reed. And so I'm going to start off, it's just a great flow from what Nicole talked about. But as you know, many of you who are interested in this area and work with these individuals living with or beyond cancer, we have these great guidelines, and they help to frame our prescriptions that we offer to participants who come into our programs or who you're working with one-on-one. And so as you're probably familiar, these guidelines were updated in 2019. They include 90 minutes of moderate intensity aerobic exercise per week, plus 2 days of strength training per week and flexibility training most days of the week. And this is great, but as we have talked about, and actually as Nicole pointed out, what a breast cancer patient who is dealing with weight management issues after her treatment versus a head and neck cancer patient who's very cachectic, has lost a lot of muscle mass, what they both need is going to be very different. And so also as a part of this publication, they talk about how exercise is safe and beneficial during treatment, that after treatment exercise is essential for recovery, and that individualizing and tailoring are key components to an effective exercise prescription. And so that's what we're going to be working on today. You may have seen this before. So this is the little diagram that we like to use that really focuses on the components of safe and effective exercise. And so safe and effective exercise has lots of different components that play into it. Number one, screening and assessment. And we talked about that if you were tuning in earlier this year when we gave a presentation talking about all different screening modalities, how you would assess somebody. Triage is another key component. And so that's where you would actually help somebody to access other healthcare professionals. Maybe if there's an issue outside of your scope of practice, you would help the individual you're working with access a professional who can really help them. So for example, if somebody's having issues with pelvic floor after a surgery, maybe they need to work with a pelvic floor physiotherapist. And there's actually a great talk coming up later this week. Maybe if they're having lots of experience of psychosocial distress, anxiety, and depression, which can be quite common, you need to help them access or provide them with the resources that you might have to access psychosocial oncology resources. Or maybe if they're starting to have acute knee pain after doing some increased exercise, they need to go see a sports medicine physician or a physiatrist to have an assessment of that knee pain so that they can get treatment and move forward with their exercise. So that's just an example of triage. And then finally, tailoring. So this is what we're going to focus on today. And tailoring is really how we adapt exercise based on individual factors. Today, we're going to focus on medical conditions, but tailoring can also be behavioral considerations. It can be different comorbidities that patient may have. Maybe they're diabetic, maybe they've had a past hip surgery that you're going to have to consider. So there can be lots of other reasons why you would tailor. Today, we're just going to focus on oncology specific medical issues that can affect exercise and teach you specifically how you would tailor exercise based on those medical conditions. I see we've had a few people join us in the last few minutes. We got started a little bit early, but you haven't missed too much. We're just diving in right now to how we would tailor exercise based on medical conditions. And Max actually posted in the chat box a worksheet that you can download, you can print, and that you can use as we work along. So it's up to you whether you use this, but I thought it would be a way to keep us engaged because we have a lot of content to cover. We're actually basing a lot of today's talk off of a publication that we had earlier this year. And so this was it's hot off the press, and we're going to be talking about a few of the medical conditions that are highlighted in this paper. There's a lot more highlighted in this paper that I didn't have time to address today. And so if you are interested, you can look this up and see other additional ways to tailor. But I'm going to talk specifically about a few things that I think you're actually going to face when working with patients. And in medicine, for those of you who work, many of you who work in the medical field as an exercise specialist or exercise professional, you may have seen that we like to categorize things as common and rare but serious. And so whenever in medicine we're faced with something, we think, okay, what's the most common thing this could be? And what are rare but serious things that we have to rule out? And so how I'm presenting this talk today is around common things that you're going to see and how you're going to tailor exercise, and then rare but serious things that you might see and how you would tailor exercise based on that. Okay. So your worksheet is set up like this. You have common, and then you have rare but serious. You're going to have an area on the worksheet for a little description of the actual medical issue, and then an area where you would just put down a few notes to tailor exercise. And so you're welcome to use that again, but it's just an option. So we're going to start with the common things. So you can see there's a list of 9 things we're going to address today. And again, you're going to get these slides after. So all of this is going to be available to you. And so you don't have to write anything down if you choose. It'll all be available to you. I'm going to start off by talking about lines and tubes. And I remember when I was working as a exercise physiologist before I went into my medical training, I really felt intimidated by different lines and tubes that people may have. And I didn't know how would I adapt exercise. I don't even understand what this line or tube is. And I want to make sure that this individual is safe. And so I have explicit pictures here to show you exactly what actually happens with specific lines that are used often in cancer treatment. And so we're going to start off with a PICC line. And so you can see on the right-hand side of the slide here. So a PICC line is a tube that's inserted into a vein in the arm or leg with the tip of the catheter positioned into a large vein that goes directly, the vein feeds directly into the heart and pumps the medication around the system. Okay, so a PICC line's often what you'll see is it's in the forearm of the individual. And so it goes into that vein and it's allowing access. And the reason we use lines and tubes like this is it's really difficult to constantly try and access a little tiny vein. They all start to collapse on you and you can't get access to them, especially when you're using a chemotherapeutic agent. So lots of these patients will have a tube into a larger vein. And so medication can be put in, the vein isn't going to collapse, and it's easier for that patient. They don't have to get poked every time. And they can go home with this. They can shower, they can do their activities, but they just have to be careful about keeping that site safe. A central venous catheter or a central line. So this is similar, but it comes further up. So it's right onto the right side of the chest, right into the superior vena cava, or a vein that's right close there, feeds right into the heart. But again, if they're receiving a medication that's can damage the veins, they want to give it right into the heart or very close to it. So it's not going to collapse those smaller veins. And so you might see that people have a central line. A port is similar, but it's actually surgically implanted under the skin. So you may actually see this. It's a little pocket that you can kind of see and you could palpate or you could feel right underneath the person's skin. And they would actually put a needle into the skin, into the little port, and then the medication would feed right through. So those are 3 different examples of lines. And I'm now going to talk about an ostomy. So people who have had colorectal cancer, for example, they may have had a surgery where the exit of their bowel contents is actually moved just to be outside of the abdomen. And these can be in different locations. So the small intestines, you can have an ileostomy, or a colostomy can be part of the colon. And that's just a direct line right out, so the bowel contents are collected. If they have a cancer that has to be removed from the rest that actually connects with the rectum, where they would actually expel the bowel contents normally previous to their cancer. And so somebody who has this, they'll have a collection bag, and they'll just be able to empty the contents into the collection bag, and it'll happen all throughout the day. Then they would clear out that collection bag. So that's a quick description. We're going to start with your first considerations. So for lines and tubes, here's some things that you're going to need to consider. Number one, exercise is safe with lines, tubes, and ostomies. That's as long as they're stable, they've undergone the surgical procedure if need be, and they've had at least 6 weeks where they're now stable, the skin is healed. So a few things for you to consider. Number one, the site is clean and dry before and after exercise. And this is something that you won't have to do, but something that the client or the patient or the participant you're working with would actually manage, but you can remind them just to make sure that you're having safe exercise. Make sure the line or site is clean and clear. Number two, a pick, port, and central line. So modify exercise to avoid pulling, friction around the line, or avoid activities that could cause pain or discomfort at the site. And then with an ostomy, you want to encourage patients to wear comfortable clothes and help them actually secure the ostomy bag in sight. So some of them may have tight-fitting clothing to help secure the site, or they may have a band that they wear around it to secure the ostomy bag. This is actually something I hear quite commonly with patients on our unit or with patients that I see in the hospital. They're worried about their exercise or rehabilitation after they've changed their ostomy bag. They feel like it won't be stuck well enough yet. So you can tell the person, if you're exercising with them on Tuesday and Thursday, maybe they're changing their bag, on Monday and Wednesday, and making sure it's nice and sealed before they're working with you, because it can be a barrier for participants. Avoid activities that cause pain or discomfort in that area, and then evaluate any significant change in that ostomy output, which the individual would likely know to do. And that's when they can actually go and seek consultation from their medical practitioner if they're noticing that. It's best if they empty the ostomy bag before exercise. It'll be more comfortable for them. And then avoid Valsalva maneuver during exercise. So make sure they're doing a really good exhalation during any big movements, because they can actually, some of the part of the stoma can actually expel itself if they're doing a Valsalva. So that's your first thing. We're moving on to number two. This is pain. So we're going to talk a little bit about pain here. And pain, as you know, is something that's highly experienced by individuals with cancer. 70% of patients or individuals living with and beyond cancer can experience pain. And it can be acute, which is defined as less than 3 months of experience of pain, or chronic, more than 3 months. There's different types of pain, and I've outlined them here just for your knowledge, because we're going to actually talk about neuropathic pain, and people may have nociceptive type pain. And so I'm going to explain the differences, because I think it's really important to understand when someone has different types of pain, they're going to have different types of treatment for that pain. So neuropathic pain is a nerve pain. So that may be described to you as they're experiencing burning, temperature changes, pins and needles, okay? Or nociceptive pain. So this is related to damage of the tissues. So there can be visceral type pain, so injury to internal organs, or somatic type pain. So this is damage to tissues like the skin, muscle, or bone. So you probably have experienced people with both of these types of pain. You may have experienced both these types of pain. If you fell down and banged your knee, you would experience nociceptive pain, somatic. It would hurt the tissues. You would have tissue damage immediately if you scraped up your knee, for example. If someone's had a recent surgery, they would have maybe visceral type. So it's kind of those internal organs, but it's due to tissue damage. Whereas neuropathic pain, so you may have, experience kind of a burning type pain, pins and needles if your leg went asleep, for example, and that's can be more of that nerve pain. So you pinched a nerve and then you're getting some of that burning type pain. So they're different and they're treated differently. So people are going to be on different treatment regimes because of it. So in terms of considerations, we're actually going to come back to neuropathic pain because we're going to talk about CIPN, which is chemotherapy-induced peripheral neuropathy, so a type of neuropathic pain. But in general, for pain considerations, so number one, continue with current levels of activity using pain as a guide. A really good tip is to use visual analog scales to measure pain before and after an exercise session. And this can be hugely helpful for you when you're designing the exercise program, but also for the individual. When they're exercising independently, they can actually decide, actually this increased my pain right after the session or the next day. This really increased my pain. Or, you know what, my pain was a 5 out of 10 when I started, and it was a 5 out of 10 when I ended. So it didn't actually impact my pain specifically. It can be helpful for you because if they actually are documenting in a journal, for example, what their pain was before and after, and you can target, okay, it might have been this exercise that made your knee pain worse, we're going to adapt to this exercise. And so really helping them work around that specific type pain is important. So think about including light stretching or light intense aerobic exercise on days when chronic pain is worse. Many individuals will be living with that chronic pain, so greater than 3 months of pain. And so helping them adapt with how they're going to exercise even while living with chronic pain is important. They're going to be experiencing this pain ongoing, and hopefully their medical team is helping to manage it, but this may be something that they're continuing to experience. And so really we have to work to how we integrate exercise and work with that as a barrier and help them integrate exercise around that barrier. Educate patients about delayed onset muscle soreness. So we probably all of you do this very well in your practice, but talk to them about how there can be good types of pain. So when you're feeling stiff or a bit sore the next day, that can be a really good sign that your muscles are working, your muscles are changing. And so that's not a negative pain. If it starts to become debilitating, they're not able to walk the next day because of it. Yeah, maybe they went too hard and you need to modify, but teach them about good types of pain that they can actually work with. And that gives them a sign that they actually are changing their muscles, as long as it's not debilitating for them. And then if they're starting to experience pain that's getting higher than 6, 7, 8, 9, or 10 on that visual analog scale, so a scale from 0 to 10, where 10 is the worst type pain, they may need to go back to their oncologist, their family doctor, their physiatrist, and actually talk about getting better pain management strategies. Number 3, cancer-related fatigue. So we're working our way down the common things that you're going to see, common medical issues you're going to see. And this is one that's going to top the list as one of the most common and most distressing symptoms that patients experience. Fatigue is multifactorial, as you can see here, and often secondary to increased inflammation in the body, changes in endocrine function, metabolic causes, deconditioning, treatment side effects, psychosocial factors, comorbid conditions, lots of different factors that can actually play into chronic fatigue, cancer-related fatigue. And this is a fatigue that's not just made better by rest. And so this can be a debilitating fatigue that's hard for people to go about their day-to-day activities. And so we need to really help. Once again, this can be something they continue to experience. We need to really help people modify their exercise so that they can continue to be active despite experiencing cancer-related fatigue. And so here's a few suggestions for you. Once again, come back to a visual analog scale. You could actually print off the internet a scale from 0 to 10. You could use it for pain. You could use it for fatigue, but sometimes just having that visual cue right in front of your client or your patient so they can rate for you. I'm a 6.5 today. Great. Next time, where are you? I'm a 5.5. Okay, we're starting to notice some changes in this. What's the impact of exercise? Fatigue is one of those things in lots of the studies that we run, we'll actually do before and after class visual analog scales for fatigue. And this is so interesting because patients can often report that fatigue can be a barrier to them participating in exercise. But when you actually look at the research and see over the period of an exercise session, the majority of people actually report that fatigue decreases. And so exercise is reported to be a key and evidence-based tool in decreasing fatigue. A few other key points. So use a tailored approach to exercise. Focus on lower intensity exercise the days with higher fatigue. Just like pain, you're going to use some of the same strategies. Avoid progression or changes in the exercise program where you're actually increasing the intensity if somebody's experiencing fatigue. So maybe adapting exercises so it's not more intense on those days that they're feeling more fatigue. Aerobic exercise has been shown to have some of the most evidence around managing fatigue. And then really provide reassurance that physical activity or exercise, when performed properly, should not worsen fatigue symptoms and actually is a key ingredient to helping them manage their fatigue. We're moving on next to lymphedema. So hopefully you're all doing well. I'm going to open it up to questions at the end. And so if you do have questions, please write down the slide number or write down the title that we're at, and we'll come back to these slides. But hopefully you're still engaged or using that worksheet if you need to. Let's talk about lymphedema. So first of all, the lymph system. So just like you have the circulatory system with arteries and veins that pump blood around the body, you have a lymphatic system. And lymphatic system is a similar network of vessels and lymph nodes, and they collect and carry fluid throughout the body. And one of the key purposes of that fluid is really to help in the immune system function. And so lots of extra fluid that's left behind is collected. And then you have these immune factors that are stored within that lymph fluid that help to ward off infection. Now, the lymph system can be affected with cancer treatments. And so people undergoing surgery, for example, who have had lymph nodes removed or radiation can actually have damage to that lymphatic system, and people can have difficulties with draining how they usually would with lymphatic fluid. And so you can start to see people, there's an image here, for example. So you can see here, this is the normal limb, and this is the limb affected by lymphedema. This is an example of a garment, a compression garment that helps to manage lymphedema and to add extra compression to help pump that lymph fluid back. So just hearing that word, pump lymph fluid, what else do you think helps to pump lymph fluid back? Exercise. So exercise is a fantastic tool to help manage lymphedema. So in the past, you may have heard that too high intensity exercise or too heavy weights, for example, can exacerbate or make lymphedema worse. And this can be true if it's an acute change in exercise and if it's too much exercise at one time. But if it's the appropriate tailored exercise, it's actually really effective in helping to pump muscles, which help to then pump lymphatic fluid back into the system. So let's talk about how you would modify exercise if somebody has lymphedema. And I just because in the title, we often talk about lymphedema, but also metastatic disease to the lymph system. And this can be, people can experience metastatic disease to all different tissues, but the lymphatic system is one of those circulatory or tissues that it can experience metastases and also contribute to lymphedema then. So the first consideration, obtain doctor's consent prior to exercise if there's a change in lymph volume or the patient starts to complain of heaviness in that limb. This doesn't just mean in the upper extremity or in the arm. People can get lymphedema under the chin if they have gone through head and neck cancer treatments, for example, or surgery. They can get it into the groin or the lower extremity if they've had surgeries in the abdominal region or into the pelvic region. And so this can affect people in all different parts of their body. We say obtain doctor's consent or consultation, but really the leading experts in the area of lymphedema are physiotherapists and manual lymph. They often do much of the manual lymph drainage and the fitting of the garments. And so working closely with them, talking with them, if you have somebody who's dealing with lymphedema, can be very helpful because they can help give a guide around how to modify exercise. A few other tips. So a participant can continue to do activity at current levels as long as it does not worsen their symptoms. Stop exercise if. So these are some key things to keep in mind. Cellulitis, that's an infection of the skin. It'll start to become red, inflamed, start to become swollen. So they need to go and see a healthcare practitioner if they're developing cellulitis or an infection. Lymphorrhea, so that's where they start to actually have dripping or drainage through the skin of the lymph tissue or the lymph fluid. Or subcutaneous infectious signs. So they're starting to feel unwell. They're starting to have maybe some, swelling like we've talked about. They're starting to feel fever or fluish. That's a sign that they're having an infection that may be related to the lymph tissue. or the lymph fluid. They're actually at increased risks of infection if they have lymphedema, because that fluid can pool. And whenever you have pooling fluid, you're at risk for an infection. And so that's why we want to make sure the fluid's draining and that somebody doesn't have a lot of fluid into that limb. Ensure that they're undergoing ongoing treatment for the lymphedema by a certified lymphedema therapist. And so they're actually getting that decongestive therapy and maintenance therapy to help get the fluid out of the limb, and that they're actually wearing their compression garments if they've been prescribed. So this is something that should be prescribed by a healthcare practitioner or an expert in the area of lymphedema. So not by a qualified exercise professional unless you have this level of training. Let's move on to bone health. And so we're going to talk about bone health in two different ways. One is osteoporosis and osteopenia. And then we're going to talk about bone metastases. These are very different things. They're treated very differently, and they come with their own set of consequences. So I wanted to separate them into two different categories. So here, osteoporosis and osteopenia. You may be well aware that osteoporosis or penia, so osteopenia is usually the term used when someone's at risk for osteoporosis. So those early changes in bone where they start to have decreased integrity of the bone tissue. And this is progressive. So over time, people may have decreased bone mass that can put them at risk for fractures. Many of the treatment agents that are offered to patients can actually increase the risk of osteoporosis. And so patients can have weaker bones as they go through treatment. Other risk factors can be age, lifestyle factors. For example, if they don't do a lot of weight-bearing exercise, genetic factors, females are higher risk than males, endocrine disorders that people may have, and then cancer treatments, as we've talked about. Now, remember, this is the key point with osteoporosis, is that bone responds well. When people have osteoporosis, bone responds well to actually loading activities. So to actually make the bone stronger, we want to load the bone. We want people to do weight-bearing activities, for example, standing with squats, holding weights, maybe walking lunges. And so we're going to treat osteoporosis by working on bone loading activities. We're not going to treat bone metastases in the same way. So I really want you to separate them in your head. The other thing is when people have osteoporosis, they can be at risk for fractures if they fall, for example. So making sure you set up a good environment. So no rugs, mats on the floors. They have well-fitting shoes, for example. If they have a neuropathy, they're having difficulty sensing where their feet are in space, for example, because their nerves aren't working as they should. Be extra careful that they're actually have a really safe environment with no obstacles around them. And maybe you're doing seated activities to start and then working up to standing so they can get more bone loading activities. Gentle twisting is allowed as long as it's pain-free and tolerated by the individual as well. So again, loading the spine will help if they're at risk for osteoporosis or osteopenia. Okay, let's move on to chemotherapy-induced peripheral neuropathy, or CIPN. So I mentioned when we talked about pain that we would come back to a type of neuropathic pain called chemotherapy-induced peripheral neuropathy. So what patients will experience is tingling, numbness, changes to sensation of temperature, so cold or hot, and it usually presents in a glove and stocking pattern. So just imagine if somebody had gloves on and stockings on, those tiny nerves get damaged first, and so they can start to notice it in their hands and their feet. And it's specific types of chemotherapy agents. And so I've actually listed them on here so that when you're doing the health history with the patient or your client or individual with cancer, you can actually look and see, oh, they've actually received a taxane or a platinum agent. And then you can think, I need to be aware that they might have chemotherapy-induced peripheral neuropathy. Can everybody hear me? My internet just told me it was unstable. We're good? Okay, good. So we talked about some of the symptoms. If someone has ongoing neuropathy, it can actually worsen to the point where they have difficulty with proprioception or telling where they are in space. So gait ataxia or incoordination of gait, being off balance, can start to occur, or it can be difficult for them to hold heavy objects. So heavy objects may actually fall out of their hands. They may have difficulty doing buttons, for example, things that require dexterity or movement or understanding where their fingers or hands are in space or where their feet are in space. Okay. So this really helps you think about how we would modify exercise based on this. So number one, similar to the other things, the patient should see their physician if there's new or worsening numbness or tingling in the hands and feet, but they can continue with exercise with modification. So this doesn't mean they're unable to exercise. Refer them back to their doctor, ask them to see their physician if they haven't yet talked to their physician about this, but you can continue to be active with them. And I think really one of the goals today I should mention is, just like Dr. Kulos-Reed said, we want people to be active and we want to help them integrate exercise into their lives. And so the reason we're giving this talk about how to tailor exercise is these things, we don't want them to act as barriers. We want you to have the skills so you can modify exercise so that people can be safe and they can get effective exercise, but it's not a barrier for them to be active if they have CIPN, because it can be a common thing. And so telling them to go back to their doctor, but modifying their exercise, because now you know how, is going to be excellent for that individual, because then they can start being active or continue to be active. One thing, perform baseline functional measurements and look at the strength and balance of that individual. So you can look at neurologic strength. You know, you don't have to, that's one of the ways that we report it as physicians in terms of what their strength rating may be, but you probably have your own assessments that you'll use to manage their strength, but actually look at strength and not just major muscles like their biceps, triceps, quads, but actually look at the strength in their hands, the strength in their ankles, for example, because that may actually be affected later on. And then assessing their balance will be really important, especially because if they're on active treatment where there is evidence for the role of exercise in actually helping to decrease the experience of CIPN, actually doing balance exercises is really important for them, but actually see what's their balance today and what's their balance in a month from now can be really helpful. Prescribe exercise considering the safety within their capabilities. So if they're having a lot of difficulty with standing and they're having a lot of gait ataxia or incoordination, get them to do seated or closed chain exercises so that it's safer for them. The last thing you want is for them to fall. Use bands or body weight if they're having upper extremity symptoms. So if they're having symptoms in their hands, heavy weights may be dropped, just like we talked about. And then again, if it starts to get worse, seeing their physician is really important. Let's talk about chemotherapy-related cognitive impairment. And one of the terms that can be used is brain fog, but really the idea is chemotherapy-related cognitive impairment. People can have chemotherapy or brain fog or changes in their cognitive function with other types of treatments as well. So maybe they've had a surgery that's removed a tumor into the brain. Maybe they've had radiation therapy. And so this is actually similar in how you would modify, but today I'm just focusing on the evidence and the recommendations around chemotherapy related cognitive changes. So this can affect upwards of 75% of patients who are receiving certain types of chemotherapy, and upwards of 30% of those patients report long-term changes. And it's thought secondary from the toxicities that can happen from certain chemotherapies, as well as the effects of, like we talked about, radiation, anesthetic that they may get from certain surgeries, genetic factors, endocrine or inflammatory factors, and then other things like their changes in sleep or their changes in their actual cognitive demand, for example, if they're not working anymore. And so ways that you're actually going to modify this. So exercise is a key factor when we look at improving cognitive function. And so it's really important in cancer and non-cancer patients too, that you're including an exercise intervention to help these people with increasing blood flow to the brain and helping those cells recover or become neuroplastic, so actually change and adapt. Include activities that are aerobic exercise, resistance, and flexibility exercise at moderate intensity, and then work up as tolerated. There's actually really good evidence also for activities like yoga, qigong, tai chi. So including lots of different therapy or different exercise or movement-based therapies can be really useful for individuals with brain fog. Some of the adaptations are really around helping people understand the instruction and making sure you repeat yourself at next session and the session after that, because they may have difficulties with memory, short-term memory specifically. And so show people in a variety of different ways I found one of the strategies I often use when working with patients is actually demonstrating, putting my hands on them and showing them physically, giving them a diagram or printout, and then a written description. And that way they have 4 different ways that they're actually getting that feedback. Next, make sure that they're able to adhere to proper techniques. So they may require ongoing cueing, and then consider supervised exercise in this population. Let's move on to changes in body composition. So we're just about getting to the end of our common conditions, medical conditions. I hope you're all still with me and doing well. I know it's a lot of content, but I really hope that this will empower you to make these adaptations with your clients. So there can be lots of different changes in body composition. You all know sarcopenia quite well. You all are the champions in preventing sarcopenia with your clients who you work with, because this is the loss of skeletal muscle mass as we age. Cachexia is actually a multifactorial inflammatory type syndrome that actually causes progressive muscle wasting more than fat loss. And people who are undergoing cancer treatment or who have a diagnosis of cancer can experience cachexia. Cachexia is not as easy as sarcopenia to treat. So just by doing more bicep curls doesn't actually mean that you're going to actually prevent some of that muscle wasting due to this ongoing inflammatory process, but it definitely helps and is an important factor in their treatment. So a few considerations is really focusing on muscle mass building. And so that's going to be exercises, resistance training exercises that target large muscle groups, and that can help to prevent that decline in muscle weight, or that progression of muscle wasting. And the other thing is nutrition support is really important here. So people who are having this inflammatory response, having higher protein diets can be quite helpful and is found in the research. And so maybe helping to connect the individual you're working with a registered dietitian or a nutrition expert to actually help with some of those diet modifications. Let's move on now to some of these blood changes that can happen. And again, when I remember before being in medicine and working with individuals with cancer, this felt a bit intimidating to me in understanding why everyone was so worried about febrile neutropenia, or when somebody starts to get really low blood counts, what am I supposed to do about it? And why am I so worried? And how am I supposed to intervene as an exercise professional? And so obviously this is a medical condition and this will be treated by the medical team, but it's actually really empowering to know, okay, this is what's happening. And this is some considerations I would have around exercise. So I'm going to present this a little bit differently. I'm going to actually tell you the blood marker, the number cutoff. That's not necessarily important to you because you're not going to be reading their blood cell reports, but I'm just going to talk about some considerations around it. So before we jump into that, I should explain red blood cells. So red blood cell marker measured in your blood is hemoglobin. When somebody has low hemoglobin, they're anemic. Okay, you probably all know that, if you've experienced maybe yourself or other people in your family who have been anemic. There's lots of reasons for anemia, lots of different things that can be contributing. One of them is cancer or treatments. Platelets, so this is one of your clotting factors in your blood. If you have low platelets, it's called thrombocytopenia because the little platelet cell is called a thrombocyte. If you have low platelets, your risk of bleeding increases. And then there's a number of white blood cells. Okay, and low white blood cells is called leukopenia in general, but one of the ones we really focus on is a neutrophil. And neutrophils make up 70% of your white blood cells. They're essential for innate immune system function and killing and warding off bacteria and infection. So we really care about the neutrophil. When the neutrophils are low, we can't ward off infection. That's why we're so worried about neutropenia. So I'm going to talk about how you would adapt. And again, you're going to get these slides, so it'll talk more specifically about these different things and just to be aware of it. So if you're, the purpose that the reason I'm including this information, I won't go through every single point and read it to you here, but I want you to see what you're going to be getting. So you will have reason to come back to these slides if you're faced with this. If your client comes to you and says, I've been quite anemic from actually doing my cancer treatments, then you're actually going to know, okay, what the cutoffs would be where you would actually adjust exercise intervention if they have those numbers, okay? And actually thinking about at different levels, how would you change exercise? So, if somebody has a hemoglobin of 100, they can still participate in exercise just fine. So our normal hemoglobin would be around 120 to 140. And if they're kind of down to 100, they can be fine. If they drop between 80 and 100, 8 grams per deciliter is used in the US. So if you're signing in from the States, that's what you'll see. Grams per liter is what we use here in Canada. Both are given here. So if they're lower, 80 to 100, monitor for signs of fatigue. That's going to be your biggest signal. And then adjust exercise intensity according to the fatigue guidelines that we gave you. If they're below 80, this is where they should obtain doctor consent. Most people below 80, they may be hospitalized at that point, receiving a blood transfusion. We often transfuse if people drop below 70, but they'll be very fatigued. And so if you're having someone come to you and all of a sudden they're undergoing treatment and they're so fatigued, they may actually be anemic and need to go back and see their healthcare provider. These blood markers are often tracked weekly or multiple times in the week to make sure if they're receiving active treatments. So the same type of idea I've gone through for thrombocytopenia. So that's the low, that's your clotting factors, so low platelets. And so the thing to watch for is if they have increased bleeding. And so if somebody is starting to present and they're having, increased nosebleeds, or, they have a little bruising all over their body, could be because they have thrombocytopenia and their platelets are low. So really, it's just going to be around being careful that they're not hitting themselves or hurting themselves. And if they're having a lot of bleeding, that they're actually talking to their oncologist or their family doctor. And this is the white blood cells. So leukopenia. So this is where all white blood cells are low. And neutropenia, which is the big one that we really think about, is where all the neutrophils are actually low. So our ability to ward off infection is quite low. And the big thing here, if people have low white blood cell or low neutrophils, is around infection prevention. And so the environment is, we're living in the time of COVID, so we're all very aware of how to prevent infection. And so being extra cautious for individuals like this, maybe you're actually engaging in exercise remotely with them, because the risk if they come in to a center would be much higher because they just don't have the ability to ward off infection. Hand washing, wearing masks, if you're seeing them face to face, making sure that all the equipment is very well sanitized. All of those things are very important for these individuals. Just to give you context, if someone drops their neutrophils to a significant level, cancer treatments will actually be halted or their doses will be reduced. So this can really impact their ability to continue to receive the treatment that they need to receive. And so we want to really help them continue with exercise, but make sure they're doing it safely. So we've talked about everything with the common. So I hope that was helpful. And we're now going to move into talking about rare but serious. And there's less of them, so it'll take us a bit less time. But one thing I wanted to mention is remember that people may have other things that may also require tailoring. So they may have osteoarthritis and pain in their hip or knees. They may have diabetes, asthma, cardiovascular disease, COPD. And you're already experts at this. And I feel like we get actually a lot of teaching in our training to actually modify exercise based on these factors. But just don't forget that just because they have cancer, you don't have to worry about modifying exercise for all these other components. So let's move into rare but serious. And the things we're going to target here are metastatic bone disease, different than osteoporosis, cardiovascular complications, respiratory complications, spinal cord compression, and brain metastases. So let's start off with metastatic bone disease. I hope you're all doing well. Do some stretches or exercises to keep yourself engaged. I know this is a lot of content. Okay, so most common cancers that metastasize to the brain, to the bone. So cancers that tend to metastasize the bone: breast, prostate, lung, kidney, thyroid, uterine. The way that we all remember it through our medical training is often paired organs have a high likelihood of going to the bone. Okay, so breast, lung, kidney, those are all paired organs. Thyroid kind of has two sides to it. And then other things like prostate and uterine as well. But those are kind of some of the key ways to think, okay, somebody is coming to me, they have breast cancer, they have lung cancer, they have kidney cancer. I need to really think about bone because those are paired organs. If they have symptoms of pain, that would be the most common symptom that people would experience if they're having mets to the bone. So you can have a primary bone tumor, less common. More common would be probably to see somebody with metastatic disease to the bone. And mainly they would have bone pain. That would be one of their first presenting complaints. And obviously they need to go to their doctor. They need to have scans and a workup to diagnose that they have metastatic bone disease. There's different types of metastatic bone disease. So osteolytic and osteoblastic. So you don't need to know the intricate details of the differences, but one is where it eats away at the bone. The other one is where you start to have extra bone all compacted together, which you would think would make bone stronger, but it doesn't. It makes it rigid and more prone to fracture. So with both of these, people have increased risk for fracture. Osteolytic lesions, for example, somebody who has multiple myeloma. Osteoblastic lesions, for example, somebody who has prostate cancer. So different cancers are associated with these different types of bone metastases. So I'll just talk about here. I've actually explained what I just said. I should have flipped to this slide, but it actually goes through what's osteoblastic, what's osteolytic. People can have mixed, so in breast cancer, for example, and then it actually gives you the examples we talked about. So the big consideration here is individuals are more at risk of fracture if there's any torque or pressure applied to that bone. Once again, this does not mean they should not participate in exercise. Actually, the complete opposite. So if somebody starts to become more and more frail and they fall and they have metastatic bone disease, their likelihood of fracturing is through the roof. But if you've helped them to become strong, independent, have strong balance, have good muscles, they're going to have decreased risk of falls, which will mean they'll have decreased risk of fracture. The key is we need to tailor exercise so they actually are doing it properly to prevent any fractures. And this is really, really, there's a lot of detail here in the description, but it actually tells you about how you can modify exercise based on where the bone metastases is. The key take-home point, so if you're using that little worksheet, the take-home point is to avoid torque over an area where there's metastatic bone. There's a new set of guidelines going to be published within the next few months, giving specific exercise details on how you would modify. Those aren't available just yet. But until that point, most publications really talk about avoiding acute torque over an area of a bony lesion. So for example, if they had a femur with a metastatic lesion, you would want to avoid a lot of torque over that actual over the femur. So want to be really careful about an exercise where you're kind of getting them to kind of extend at the knee, for example, while they're holding their torso still, if that's going to apply a lot of pressure over the femur. But there's a lot of other things that they can do. So maybe they're doing body weight exercises, so there's not extra torque, it's just using their body weight. An example given here, so based on the literature, they actually talk about if there's metastatic disease in the axial skeleton, so in the spine, limit simultaneous bending and lifting or twisting and lifting, because that's going to put a lot of pressure over that vertebrae, right? Choose activities like partial weight bearing or machine assisted. So I remember first reading this thinking, oh my gosh, we're going to be getting these people to do pull-ups, but you're not actually loading over the spine that way, right? You're extending in the spine. So maybe machine assisted pull-ups, push-ups, or dips if they don't have upper extremity metastases. Those are really good exercises that you could actually do that would take pressure off of loading the spine. So just think about different than if you actually put a weight on somebody's shoulders and getting them to really load their spine, or even worse would be twisting with that. That's not what you want to do if they have axial skeleton metastases. You would actually want to decrease that load on the spine, but still work their upper body in different ways. So there's some examples there. If there's disease to the pelvis or femur, so avoiding flexion and extension of the hip, but flexion and extension of the knee is allowed. So we talked about kind of flexion extension of the hip, but allowing them to, especially in a seated position, and doing kind of flexion extension of the knee if they're stable, then that's okay. And really kind of just applying those same principles of avoiding high impact exercise. So no kind of jumping, leaping, rebounding. That's going to put them at risk if they have lower extremity metastases. So I hope one of my take homes for you today is really knowing the difference between osteoporosis, bone loading, metastatic bone disease. Don't load the direct bone, but get them to be active in other ways and work on strengthening. Next up is cardiovascular considerations. So people who use cardiotoxic or who are given cardiotoxic medications can actually experience different cardiomyopathies. So that's disease to the heart muscle. And so there can be lots of different presentations of this. So they can get a dilated cardiomyopathy. You'll see that this doesn't look the same as the normal because it's dilated into the ventricle. They can get hypertrophic cardiomyopathy. So they start to get a lot of that muscle is getting too thick, or restrictive. So they're not actually getting that nice expansion in the ventricle to pump the blood. There's certain chemotherapeutic agents that can contribute to this. So just like chemotherapy-induced peripheral neuropathy, being aware of what those agents are, just so if the person fills out their health history form, you can actually think, okay, I need to be more aware that they may have cardiomyopathy. I'm going to ask them, have you ever been diagnosed with any cardiomyopathy or any difficulties with your heart function after your treatments? Yes, actually, my cardiologist or my oncologist told me I have to limit exercise to this heart rate. Great, that's what you can work with. If they are receiving a treatment like that, they will be referred to a clinic where they'll have cardiac testing so that most of them will actually receive parameters, but it's very closely monitored. So the oncologist knows that they're getting a cardiotoxic treatment, and then this will be quite monitored very closely for them. And so a few considerations. Any new signs in cardiac function or symptoms. So if they're starting to get chest pain, shortness of breath when they didn't usually get it, if they're starting to get perspiring when they usually wouldn't, if they're starting to get palpitations or angina, that chest tightness or pain, they need to go see a healthcare practitioner, obviously, before they're changing or increasing their activity. That's really important. And then tailor exercise based on recommendations they may have been given if they've received a cardiotoxic treatment. Start low and increase slowly, we always say. Focus on aerobic exercise. So just like somebody after a heart attack or after they've had damage to the heart, exercise is one of the best treatments. We want them to actually increase their ability to tolerate exercise because that's the point of the heart's function. We want to increase that heart function. You just need to start slowly and progress. The other thing that can happen with heart function is people can actually start to get autonomic changes. So your autonomic nervous system is what controls your heart rate, your blood pressure. And so people might start to get dizziness, for example, if they start to get up. Their ability to adapt to a change in their demand of their heart can change. And it may not be as fast as what it was before. So in this case, we talk about actually getting patients to do a longer warm up, a longer cool down, being careful of acute changes in position. So slowly getting up from the ground or the chair and slowly getting down. So just be very cautious or aware that people may actually get these autonomic changes as well. Let's talk about respiratory complications now. So shortness of breath or dyspnea is an experience where people can have difficulties catching their breath or have air hunger, for example. And there can be lots of different reasons for this. So they may actually have a primary lung cancer. So a cancer in the lung tissue, it's taking up space. There's no air exchange that can happen where the tumor is taking up space. They may have lung metastases, once again, taking up space in the lung. So there's no air exchange there. They may have had radiation or different treatments that actually affect the integrity of the lung, or that ability to exchange oxygen or have nice full inflation or exhalation. They may have pleural effusion, so they may have fluid that's building up in the lungs. We really see this with people who have metastatic disease, especially in advanced cancer. They may have clots in the lung, so a pulmonary emboli, for example, or they may have different pleural metastases. So the pleural lining is kind of what helps to line the lung and connect the lung with the chest wall. So in terms of how you would modify, once again, if they're experiencing an acute worsening in their acute worsening and shortness of breath, they need to go see a healthcare practitioner. It's a really good reason to tell them, I want you to have this further investigated before we change your exercise. This is another really good one to use on that visual analog scale. So we have pain, we have shortness of breath, we have fatigue. So print off that scale 0 to 10 and use this, in this situation if you're experiencing shortness of breath. And once again, this can help you and help them tailor their exercise. If they are experiencing, so for example, in some of our studies that we've done with advanced lung cancer patients, we'll actually measure their oxygen saturation before and after. And so a cutoff, we want to make sure they're higher than 92. or 88 to 92 in a patient with COPD. We actually don't want somebody with COPD to be really high in their oxygen saturation because it decreases their urge to breathe. You don't need to treat that, but if you're aware they have COPD, just know their cutoffs will be a bit different. And so that's why higher than 88, but otherwise we want them above 92. And people may require oxygen supplementation, and they can still participate in exercise with their oxygen supplementation as long as they're actually meeting the oxygen requirements of that 92. We're going to move on now to spinal cord compression. And this is our second last one today. And then we're going to have 10 minutes to really open it up to questions. And so you can see an example here. So this is the vertebrae. So 1, 2, 3, 4 vertebrae. You can see the spinous processes coming off the vertebrae. The facet joints are kind of like a little bit of a facet there. And then these are the discs, intervertebral discs here. Okay. So this is the person's back here, and this is the person's front. Okay. The spinous processes are what you can feel, right? When you palpate at the back of your neck. And then this is the spinal cord. So that yellow is the spinal cord. So that's what controls all your motor sensory function down into your arms and your legs, and all the function into your organs, bowel and bladder, for example. So if there is a metastatic disease into the spine, one of the vertebrae, and it starts to compress the spinal cord, people can have acute changes in their motor function, so their strength, in their sensory function, and in their bowel and bladder. If this happens when you're with the patient, this is a medical emergency. Somebody needs to go to the emergency room because there's a limited amount of time in actually removing the tumor and preserving the spinal cord and preventing a prolonged spinal cord injury. So any signs, I bring this up as the rare but serious, any signs of this, you will know now that somebody would tell them to go in to the emergency room. I've had people actually presenting like this and sent them to the emerge, and I've been in the emerge working when people presented like this, and it is an emergency and they are right into the OR as quickly as possible. I just came off 3 months of working with spinal cord patients, and at the end of, people with advanced cancer, often these tumors are uncontrolled, and many of them will develop spinal cord injuries. People who have metastatic disease in the spine, they may develop spinal cord injuries where they're losing motor control, sensory control, bowel and bladder function, for example. And so we see them on our unit, we treat them, we help them with rehabilitation. You may see somebody who's in a wheelchair, they're a wheelchair user, and they've been released from rehabilitation unit and they're seeing physio and they're coming for you to you for exercise. And you can look up the spinal cord injury guidelines for exercise, and you can use your cancer knowledge and you can help them be active, which is wonderful. So a few things to consider. We do want people to be active, even if they've experienced, so this is after they've received medical treatment and they're now stable. So encourage aerobic resistance and flexibility exercising, focusing on improving function with activities of daily living. Consider a referral to physiotherapist if needed. Focus on passive range of motion exercises for any paralyzed limbs, for example, in their lower extremity. If it's a tumor that's affecting the cord kind of from the chest down, or maybe in the upper extremity as well, if it's in the cervical spine. And then really focus on functional exercising, addressing their neurologic deficits and training for activities of daily living around that. Okay, team, you've all done so well. I see we have 72 people on the call, which is fantastic. And this is our last and final medical issue that we're going to address tonight. There's many more in that paper that I mentioned, and I really hope this has been useful for you, but we're going to talk about this last one and open it up for questions. So the last thing is neurocognitive complications. And so we're going to talk about metastatic disease to the brain. The most common cancers associated with brain metastases: lung, breast, melanoma or skin cancer, colon, and kidney. Okay, so once again, you do your health history. Somebody reports this. This is something you're thinking in the back of your head. If they explain they have metastatic colon cancer, you're going to ask where, because you're going to wonder, has this gone to the brain, for example? They may experience a range of neurologic symptoms, including headaches, vision changes, hearing changes, confusion, seizures, changes in their behavior, all depending on where the tumor is in the brain. It would affect different parts. They may have, if it's around kind of the motor cortex or sensory cortex, they may have weakness or sensory changes, for example. And so the final considerations for tonight, if somebody is having metastatic disease to the brain, They can continue to do activity at their current levels as long as it does not worsen symptoms. Focus on functional whole body exercises. So you really see there's a trend here in the last few medical issues that we've talked about, a trend more in helping with activities of daily living and function when people have more advanced disease. So for example, so somebody who's having difficulties using their upper extremities, you're really going to focus on activities that would help promote that and work on the strength in their upper extremity. And then limit activities that increase intracerebral pressure. So inversion exercises you wouldn't want to do. You're not going to want to do headstands, for example, and Valsalva type activities. So just be wary of that. For those with changes in cognition, go back to where we talked about brain fog and use those techniques. So really lots of different forms of cueing, verbal, written, demonstration, hands-on, so that they can help to remember. And then you may be cueing every single time that you're seeing them because they may have difficulties with their memory. And of course, any new, worse, or change in symptoms, you'll refer back to the medical team. So that was a marathon. We talked about lots of different common presentations and how specifically you would tailor exercise. And then we talked about rare but serious conditions and how you would tailor exercise. And I'm just going to circle it back to this model we introduced for safe and effective exercise. It's not linear in always going in one direction. So your safe and effective exercise and tailoring may be working for a few weeks, and then someone may have a change. They're starting to get worsening in their peripheral neuropathy. So you're going to go back. You're going to think about screening them. What has changed? Triaging them. Who do they need to see? Tailoring. How do I change the exercise? So this is constantly moving back and forth. And you, as an excellent trained health and exercise professional, this is your job. This is your expertise in continuing to go through this cycle. So I'm going to stop there and open it up to questions. And yeah, I hope that was useful for you. You'll get access to these slides for more information.